recording, right? Yeah.
Perfect.
That's recording, I think. Okay, good. All right. So we're going to go get started in the interest of time. And so it's weird because normally we have a lot more people in this room, Dr. Goldenberg, but it's because it's hybrid and it's what it is. So I know Dr. Goldenberg, he told me specifically that he doesn't want a long formal presentation introduction, but I'm going to keep it short, but I'm going to keep it very relevant to this group. So, you know, I was thrilled that Alan, Dr. Tita invited Dr. Goldenberg to come back to Alabama. It's been for a long time. And I think some of you may or may not know that Dr. Goldenberg was the chair here, I think, starting in 1995, if not mistaken. And I will distinctly tell you that when I was a fellow, I remember going to his house and having beers on his porch that he used to invite all the trainees to. And that was, you know, I had these great vivid memories of going to Forest Park and having a good time. And I thought that was really cool that the chair, OB/GYN, would do that. And for me, it was a really interesting foray into the culture and the people who are here. So very, very briefly, you know, Dr. Goldenberg actually I have a lot of commonalities. We both are from the New York City area. And he went to Columbia for college, then went to Duke for medical school, and then I think went to Duke to Yale, and actually did a fellowship at the NICHD. And I think that the person that he met, according to a article that was written by him, is as a truly influential mentor was Charlie Flowers. And I want to spend just a moment talking about this because when we talked to Dr. Goldenberg over dinner last night, he shared some things that were remarkably striking that actually came out in this article that was written about him in the Grade Journal. And basically, I think, you know, Dr. Goldenberg had a tremendous amount of respect for Dr. Flowers, who was a chair before Dr. Goldenberg. He actually took over the chair in 1969. And there are a lot of things that are named after Dr. Flowers. For the residents, there's actually an award that we give out to the second year. There's actually an endowed professorship, a chair actually here at UAB that's named after Dr. Flowers. But there was actually a quote in this that's actually a quote from Dr. Goldenberg I want to say that I think will resonate with this group. And it's really a lasting legacy of him, which is Dr. Flowers was an exceptionally good doctor who had a vision of how care should be given and who should receive it and the quality of care people should receive. And to me, that's striking because I think to this day, that still is very much what the department believes in. So I think you'd be happy to know many, many years later that we're very much dedicated to that. But Dr. Goldenberg is well known nationally and internationally for his work in the areas of prematurity, preterm birth, fetal death, looking at antimicrobials for reducing preterm birth. And his most recent impact has been the area of global health, particularly reducing maternal and neonatal mortality and morbidity worldwide, has worked extensively with the Gates Foundation. He's replete of numerous awards. I'm not going to go over them, but he is a member of the former Institute of Medicine, and so which speaks to his accomplishments. But you know, I think the one thing that I am, you know, really proud of, and I asked him this question. I said, Dr. Goldenberg, what do you miss the most, or what do you remember the most as being the best aspect of UAB? And his answer instantaneously was the people. And to this day, I would argue as chair of the department, that is the singular best aspect of the Department of OB/GYN and its people. So I want our trainees not to forget that, because that is the lasting legacy that we need to pass on. And so with no further ado, I want to welcome Dr. Goldenberg. Thank you for making the trip. Absolutely thrilled to see you. We had a great time at dinner last night, so thank you.
Okay, so this is a platform. I'm not very good electronically, but I think we'll be okay. I'm going to talk today. I'm going to focus it a little bit on some of the stuff that I've done, mostly related to a couple of research platforms that I've been working on. But the general topic is pregnancy outcome in low-income countries. And what I'm hoping that you guys will do is invite me back sometime so I could really delve into some of that issue. But I'm going to talk about some of the things that I've been involved in recently. And let's see. Okay, so I'm doing something wrong. Help me, somebody. How do I just move it? Which it's this button.
This button right here.
And I've been hitting it. And
there you go.
okay, and how do I? Okay.
Now you're good. Now it should click.
Okay. Yeah, make that stuff smaller and go away. And what you guys don't need to do is see pictures of me. Okay, just in the corner. Okay, so my goals for today, number one, are to review some of the recently completed research on pregnancy outcomes in low-income countries that I've been involved in, to deal specifically with stillbirth, which has been an interest of mine for many years. Again, defined as a baby born dead at 20 weeks or more, neonatal mortality. And then because of the research platform we have, we've done a lot of research on COVID, and I wanted to present some of that. So I'm going to just focus on two research platforms. One is the Global Network, and the other is what we call the Purpose Study, which I'll go over. So let me talk about the Global Network, and UAB is a member of that through Wally Carl in the Department of Pediatrics. And it was started something like 22 years ago. It's funded by the National Institute of Child Health and Human Development, and it partners a US place like UAB and a foreign place like Zambia, University of Zambia. My major relationship, which I'll talk in more detail about, is with with Aga Khan University in Karachi. But the Global Network, the goal is to perform collaborative research focusing on leading causes of morbidity and mortality in pregnancy and early childhood. And another goal, a major goal of mine, but many of the people in that network, is to develop sustainable research infrastructure in the low-income countries in which we work. And so the Global Network has got sites in, I think, 7 countries, 8 sites. You can see them here: Guatemala, DRC, Zambia, Kenya, Pakistan, Bangladesh, and a couple sites in India. And I won't go through it all, but each of these has a US institution that they partner with. And again, UAB partners with the group in Zambia. But I'll talk about Aga Khan University, which has been, the relationship that I have with the group at Aga Khan has been one of the major things in my life. But this is a university in Karachi. That's where the Global Network site is. So the way it works, AKU and Columbia University, where I am, are partners in this Global Network site. And it's maybe important to know something about AKU. And this is in Karachi. It's a world-class university. They can literally do anything there that almost any place in the States can do in terms of sophistication. The neat thing about AKU was established by the Aga Khan in the 80s. And his goal then, which is very interesting for a country like Pakistan, was to raise the status of women in Pakistan. And there aren't many people in Pakistan with that kind of goal. But the Ismaili sect, of which he is the leader, and the Aga Khan University, its major goal is to increase or improve the health and the status of women, essentially throughout the Muslim world. So the Global Network, in its 21-year history, we have published together more than 350 papers using data, number one, from the registry, which I'm going to talk about in a minute. And there have been like 20 or 30 individual studies and 19 or 20 multi-country randomized trials. The topics addressed in the trials include prevention of postpartum hemorrhage, child malnutrition, newborn resuscitation. We did a large study on the usefulness of ultrasound in prenatal care in low-income countries. We did studies on corticosteroids. I'm going to talk a little bit about an aspirin study that we did, and many, many others. But we've also done substantial training and advancement of the foreign investigators. And this is my partner, Sarah Salim. She's, I don't know what her title in Aga Khan, but she's essentially head of a group in the health department, in the related to the health department there. This picture, she doesn't always look like this, but this is a picture of her outfit for her endowed chair ceremony. And when they cited the reasons that she became an endowed chair at Aga Khan was primarily her work with the Global Network. And I looked up before I came. She has 150 publications, 100 of them came through the Global Network. And we follow this pretty closely, but there's a whole group at Aga Khan that are working with the Global Network on various studies. And every one of them has received recognition in terms of academic advancement. A number have gone on to get their PhDs. And in fact, there are 2 people from Aga Khan who are getting their PhDs at institutions in the US. So we are extremely proud of the sort of academic advancement of the people that have participated with us in the Global Network. Let me just talk about the aspirin study. This was done by the Global Network. And I think of the many research studies done by the Global Network, this is, I think, the most important, although Wally in pediatrics might think something else. But I think the ability to reduce preterm birth is probably one of the most important things. And this study, which was 12,000 subjects, 7 sites, found that daily low-dose aspirin in prima gravidis, beginning from the first trimester, reduced preterm birth about 11% overall, but probably most important, reduced preterm birth less than 34 weeks by 25%. And so far as I know, this is the only intervention that really works. There are other people that would disagree with that, but this, I think, is a huge, important step forward. And I'll tell you the study that we're going to follow up with this towards the end of the talk, if I don't talk too much. Let me talk about the registry. And what one learns in low and middle income countries is that they don't collect. If they collect any data, it's not reliable related to pregnancy outcome. And what the Global Network did, again, Wally Carlo organized that 12, 13 years ago, was to make, to do clusters or communities in which the whole population is known, and we could actually track the pregnancy outcomes of all the women that live in a geographic area. So since 2008, we have now data on more than 750,000 pregnancies, and it's mostly good data. And I think we found that there have been 350 publications related to that data from the Global Network. And I have come to believe that the Global Network Registry is one of the few and maybe the best source of reliable pregnancy data and trends in data and trends in outcome in low-income or low and middle-income countries. This isn't meant for you to try to read, but every 3 or 4 years, the Global Network has published a journal supplement covering a bunch of different topics. And I think there have been 3 or 4 that have been published over the years. And this is the last one. The things I wanted to point out are, number one, that the authors of these papers come from all different sites in the network. Most of the people that have written the papers are junior faculty from low-income countries. A couple of people from the States have participated as well. But that this has been people have been able to use this resource to really start building their academic careers. And that's why I think having this registry is so important. The things that are highlighted, Sarah Salim worked on a study on neonatal deaths in babies, in big babies in low and middle income countries. A number of the sites in the Global Network have been interested in the relationship of hemoglobin concentrations or anemia to birth outcomes. And Pakistan, I'll talk about a little bit more, but something like 8 or 10% of the women have hemoglobins of 7 or less. And this is a huge issue in many low and middle income countries. Just above, I don't know, 5 or 6 from the bottom is a paper by Margot Harrison, who was a fellow, or actually a resident at Columbia, who decided she wanted to build her career in international health. And during her, while she was a resident, and then soon after, while she was on the faculty, she published 16 papers related to C-sections in developing countries. The paper that I wanted to talk about is by Alia Assis. She's at Columbia, she's Pakistani, and she was interested in why Pakistan outcomes are so terrible. And so it's really amazing how bad Pakistan is in terms of outcomes related to the rest of the world. So the maternal mortality rate in Pakistan was 319 per 100,000 versus an average of 124 per 100,000 in the other global network sites. Its neonatal mortality rate was 49 compared to 20 in all the other low-income countries. And its stillbirth rate was 53 per 100,000 compared to 23. And I'll show you just some country relationships. But one of the things that we were trying to understand is, why does Pakistan do so badly compared in pregnancy outcome compared to almost any other country in the world? And there are all kinds of measures for that. But what she showed in her study, that the reasons for these poor outcomes, I'm looking at the fourth number down, included that Pakistani reproductive aged women are poorly educated. So throughout the global network, the illiteracy rates may be 5 or 10%. Pakistan's in the area where we were working, where we work, is 83% of the women are illiterate. They're so poorly educated, undernourished. As I said, 10% or more have hemoglobins of 7 or less. They deliver many preterm babies, low birth weight babies, and the medical care is terrible. You put all that together, and you find almost every outcome that you look at is terrible. And I'll go through some of the numbers in just a little while. But the current global network studies, since smaller studies have suggested azithromycin just prior to delivery improves outcomes, under Alan Tita's guidance, he's the PI, the global network is undertaking a Bill and Melinda Gates funded research trial of azithromycin in labor in 34,000 women, just to give you the size of the scope of the studies that we can do. That study is, I think, about 2/3 recruited. And again, Alan is taking the lead on that and just getting this thing off the ground. I'm surprised you still have hair left on the top of your head from that. The other thing, the study that I've been more involved in, is that in 8 global network sites, we're evaluating a bunch of different things related to COVID in low-income countries. And the last one down just says, we're very interested in what the women know. The CAP is knowledge, attitude, and practice related to COVID and to COVID vaccinations. And I'll talk about that as well. So, the global network is one of the platforms I wanted to talk about. The other is called the Purpose Study. And this got started maybe 5 years ago. The person I work with at Research Triangle Institute, Beth McClure, was asked by the Gates Foundation to try to understand why a study on cause of neonatal death was going so poorly in Ethiopia. And I joined that study, and together Beth and I probably made 5 trips or 6 trips to Ethiopia. And we sort of fixed that study. But over the course of that study, the Gates Foundation asked the 2 of us, would we set up a better study in Asia? And so the sites we chose, which I'll talk about, the study became what we call Purpose. And I don't remember what Purpose stands for, but it's something. But the goal of that study was to evaluate 700 fetal deaths, 700 stillbirths, and 700 neonatal deaths for cause of death. And the Gates Foundation is interested in this because they want to do interventions to try to understand, what they could fix. And so we determined the relationship of various things, and I'll show you everything in this study, but we became very, very interested in placental malperfusion. And this was something that I've been intermittently interested in over years, but the group in Pakistan and in India both taught me a tremendous amount. But there's a thing called the Amsterdam criteria, which I didn't know about when we started the study. But this is a way of grading placentas, and instead of getting all the various diagnoses that people get when you send a placenta to lab, it comes back either maternal vascular malperfusion, fetal vascular malperfusion, or inflammation. And so for people that don't have a large bandwidth anymore, separating the placental lesions into those three things were very important. So this is the group of people on the left are part of the research team in Pakistan. The group on the right is a part of the research team in India. And I just can't tell you how good the people are in terms of work ethic, in terms of knowledge, in terms of being able to design studies. And it's been an incredible journey working with these really qualified people. I want to switch this is a study that I was involved in from a number of years ago, that we ended up looking at the usefulness of diagnostic tests to determine cause of stillbirth. And so this is a study in the US. The major point of this is that the most useful test that one could do to understand why a stillbirth occurred is to look at the placental pad. Almost nothing else is of anything that level of value. And the major point is that when you go to low and income countries, there's virtually no history of placental pathology, and among many other things. But it's very hard to know cause of death because they don't do the right studies. And so the PURPOSE study, which was again done in India and Pakistan to better assess the cause of death among stillbirths and preterm newborns. The goal was to recruit 5,000 pregnant women who, for one reason or another, would have 1,400 perinatal deaths, 700 neonatal deaths, and 700 stillbirths. And the studies were done in Davangere, India, and Karachi, Pakistan. The funding was all by the Bill and Melinda Gates Foundation. And you're going to hear me talk about the Bill and Melinda Gates Foundation a lot. They are the major organization that's funding research in low-income countries by far and away. And I think if any of us want to do stuff, that's where one has to go. So I'm not going to go through this in any detail, but before we started this study, we really went through and tried to understand what tests we needed to have in order to understand cause of death. And so I'm not going to go through this because I'm not going to have enough time. But basically, we tried to capture every piece of data that we could afford that would let us know why a particular baby died. And this is a technology that the Gates Foundation has been pushing that it turns out to be really valuable. It's called minimally invasive tissue sampling. And they've built a whole set of procedures, but it's basically needle biopsies of various organ tissues. And you use the biopsy material for histology, and you can use it for PCR. And so, in fact, the Gates Foundation just put out an RFA for teaching centers to do this around the world. We, on maybe half the babies that died, or half the stillbirths more or less, were able to get consent to perform MITs. And then the other thing that we did with the samples that we collected from it is that we did PCR, and this is again not my area of expertise, but the CDC has developed a platform with multiplex PCR that you can, on a single sample, they can tell you if one of 73 different organisms are present on that sample. So you can imagine we have samples on hundreds of women with cerebral spinal fluid and blood and liver and lung and brain and placentas, and we can tell you if any of the 73 organisms were present. And so I spend a lot of my life drowning in this morass of data, but it's incredibly interesting. So the Amsterdam consensus criteria, basically you take all the findings that are related to maternal vascular or the maternal vascular malperfusion, which are mainly infarcts, but it could all be all the rest, or fetal vascular malperfusion, which is mainly thrombosis. And the path reports that we get back say, this baby or this placenta had maternal vascular malperfusion. And you don't have to try to understand all this other stuff that, for me, made understanding placentas almost impossible. Okay, so now moving on to, let's talk about fetal death for a minute. There's some huge number of stillbirths worldwide, estimated at 3 to 6 million, and it depends in part on your definitions, but in fact, they're not really counted anywhere or in many countries. There's limited data for most low-income countries, but what is clear is the contribution of fetal deaths to adverse pregnancy outcome is large, underappreciated, and understudied. And there are many estimates, but something like 98% of the fetal deaths occur in low-income countries. So this is, we clearly see some in the United States, but compared to other countries, not very much. But this looks at stillbirth rates by country. The best countries in the world have a stillbirth rate of maybe 2 per 1,000. The United States, which is the third one down, doesn't do so well, but it has a stillbirth rate of maybe 4. Most of the global network sites, Bangladesh and DRC and Zambia, all have stillbirth rates in the 20s or low 30s. And then you have Pakistan, which has a stillbirth rate of over 50. And so one of our real goals has been trying to understand why Pakistan is so terrible. So we've published now, I don't know, between 6 and 10 papers from this data, and we're just starting to try to get into it. It's an overwhelming data set. But what we found is that in India and Pakistan, more than 50% of all the stillbirths were potentially preventable with the skills that they had and with the equipment that they had. So it wasn't like they needed really high-tech stuff. They just needed to pay attention. Non-preventable stillbirths were predominantly due to low gestational age, and we just said that because their nurseries aren't very good and babies born at less than 28 weeks don't survive, those were not really preventable stillbirths. Here, if you have a baby that's sick at 26 weeks, I'm pretty sure that the practice here would be to try to salvage that baby. But in these sites, that doesn't happen. But the major finding was that more than 70% of the stillbirths at 28 weeks or more were potentially preventable by a little better medical care. And many of them were sort of late, at late preterm or term, and they were fixable, but they weren't. So the precursor conditions for the preventable deaths, I should have said, without question, intrauterine hypoxia is by far the most common cause of stillbirth. We've looked at this a lot, but something like 80% of the stillbirths are due to intrauterine hypoxia. The precursor conditions were generally maternal vascular malperfusion, preeclampsia, and placental abruption. And that's the triad in the 2 countries that were responsible for the asphyxia and the fetal death. And again, just what I've been saying, many stillbirths could be prevented with timely discovery of preeclampsia and so forth. And then the other thing we discovered, since we had placental histology on all of these cases, since placental maternal vascular malperfusion is a precursor for preeclampsia, for fetal growth restriction, and for placental abruption, figuring out how that pathway goes from the bad placenta to those major conditions to asphyxia to death is really the story here that hopefully some of us will be able to solve over a little bit of time. And I've worked now a lot with Roberto Romero, who's at the NICHD. And basically, this is his slide that it just shows what the infarct of placental maternal vascular malperfusion is. And this slide just really talks about that a little bit. I won't go into it all, but that what he continually emphasizes that this lesion in the placenta is very similar to the lesion found in coronary arteries when people have heart attacks. And so the pathology he believes, and I'm sure he's correct, is the same. So this is from the PURPOSE study, and we looked, just focus on the top part of this. We looked at maternal vascular malperfusion and fetal vascular malperfusion. We looked at those two kinds of lesions, and we looked at it in term live births, in preterm neonatal deaths, and in fetal deaths. And the takeaway from this is that in term live births, you might find evidence of this maternal vascular malperfusion in 10 or 15%. In fetal deaths, it's 60%. And so this, we've come to believe, is the major finding starting on the pathway to stillbirth. And this is not novel to us, but what we do know is that placental histology provides more information about the cause of stillbirth than any other data, including autopsy, that the most common finding in fetal death placentas is maternal vascular malperfusion. And again, that the maternal vascular malperfusion is associated with preeclampsia, growth restriction, antenatal hemorrhage, and fetal asphyxia. And we have thought and are thinking a lot about identifying pregnancies with this lesion. How can you identify it before you actually have the placenta in your hand? And what to do about it. And these are, again, Roberto's slides, and basically takes the major obstetric outcomes and has shown in a number of studies that maternal vascular malperfusion leads to ischemic placental disease, and that looks like it's the basis of many obstetric syndromes. And then his next slide just shows that fetal death is the complication of pregnancy with the highest prevalence of placental lesions with maternal vascular malperfusion. And this comes out of mostly small studies in Detroit where he works. But basically we have shown that in low-income countries with much higher rates of stillbirth, that the same relationships seem to hold. And he's published extensively on maternal serum placental growth factor and S-FLIT and various placental outcomes. And it turns out that for these 600 or 700 stillbirths and neonatal deaths, we have maternal serum on all of them. And so what he found some funding for us to do was to measure placental growth factor and S-FLIT. And it's the ratio of those two things that look like it predicts stillbirth and predicts the placental lesions. And so we're going down that pathway, and just wanted to make clear that the labs in India and Pakistan have no trouble doing these kinds of assays. This is something I got into looking at, again, why do babies die? Why do neonates die? And like the study that we did in Ethiopia, almost all of the neonatal deaths were labeled RDS, respiratory distress syndrome. And we sort of came to the conclusion when we started looking at the data from the purpose study that wasn't the case. And that by far and away, the reason the babies were dying was that they were asphyxiated. And this is an important issue because if RDS is the most common cause of death, then groups like the Gates Foundation will focus on antenatal corticosteroids and CPAP and that sort of stuff. While birth asphyxia is the most common cause of death, the focus would be on better OB care, the ability to do cesarean sections, neonatal resuscitation, and the approach for both of those would be very different. And the Gates Foundation has gone completely down the path of antenatal corticosteroids and CPAP. So, we just sent in this data, and I'll show it to you. But because again, I'm not a pediatrician, but I've learned some things that almost any time the baby is sick, it's going to have trouble breathing. That by far and away the symptom that you see. And in low and middle income countries, that the vast majority of the time that one of the physicians see a baby breathing with difficulty, they say, oh, RDS. And they never do the tests that one needs to do to document RDS, because you need a chest x-ray, or if the baby dies, you need lung histology. They don't do that. So they just see a baby breathing, and the outcome is called RDS. It's much more difficult to prove that asphyxia is a cause of death, but you need a thorough history, you need placental, you need to look at the placenta, you need lung histology, at least, to understand that what you're dealing with is asphyxia. So we actually tried to understand what was the difference between what the physicians were reporting and what actually was happening. And the best clue to this is just on the last line. And this just shows what's happening in Pakistan, that when you ask the physician who was signing the death certificate, what was the cause of death? In this case, on the far right, lower down, 89% of the time the physician said, oh, this is RDS. On the other hand, when we presented all the data we had, which is the placental stuff, the lung biopsies and everything, to an independent panel, what they said is, no, RDS is not very common. What's really common is asphyxia. So you have this huge disparity between what I think is reality and what the discharging physicians say. And that number from the discharging physicians is what's driving practice around the world, focusing on RDS and not focusing on asphyxia. Anyway, we sent in a paper that's being reviewed. Like a lot of our papers, they're questioned because we go in different directions a lot of the time. But the title is Respiratory Distress Syndrome is Overrated. And we'll see what happens with that, especially we sent it to an OB journal, so it stands a better chance. But the outcome of all of this stuff is that birth asphyxia is an important, we think the most important cause of preterm neonatal mortality in low and middle income countries. Okay, another issue, I told you, we for every tissue, we got 73 different organisms tested for. Again, this is an immense amount of data that I am not capable of studying by myself, but we are working our way through it. But in the neonatal deaths, when we looked at the organisms that were found in brain and liver and lung, by far and away the most common organism was Acinetobacter. And I've presented this before, and they say I don't say the organism correctly, but it's something like Acinetobacter. And so the reason the babies are dying in India and Pakistan are due to this organism, much of the time. And I had never heard of Acinetobacter when I started the study. So we looked it up. It's commonly found in newborn intensive care units as a contaminant. And since we didn't find almost any Acinetobacter in the placentas, the babies had to have captured this organism or gotten infected with this organism in the nursery. We actually also saw that in the nurseries in Ethiopia, and we got no traction when we tried to present that, in large part because everybody there was focused on group B strep. And again, we looked at group B strep extensively in the placentas, the membranes, and the rectovaginal cultures, but we only saw group B strep rarely in organ cultures. And it's really, there are other reports from Pakistan and India, and it's not very common there. And so, again, the Gates Foundation is working on vaccine for group B strep. They are looking for various ways to prevent group B strep infection. And when they do all that, they won't have anything that's really helpful in India and Pakistan. So, again, we'll see. A lot of the times, the things that we've said, nobody pays any attention to, so including my children. So, but we'll see if anything happens with that. Okay, let me just switch and let me just look at the time here. Okay, I've got a few minutes. That because of the research platform we had when COVID became available, we decided we really needed to use this research platform to start looking at what we could with COVID. And so we had a number of different goals, including trying to understand the relationship of medical care to outcome. We wanted to know the knowledge, attitude, and practice related to COVID and to vaccination. And then on some large number of women, we had collected, or we do collect, serum at delivery for antibodies. So I'm just going to go through that pretty quickly. So the knowledge, attitude, and practice, first of all, we started this maybe a year ago. We have, I think it's now close to 40,000 women that have answered the questionnaires, with some split among the different sites in the global network. We took the data through August 2021, through 5 months ago or so, and that paper has been accepted at the British Journal of OBGYN. And what I'll show you is some of the data from that paper. But we asked the women, number one, what did they know the symptoms of COVID? And you can see the very large variability. The very low bar on the left is the Democratic Republic of the Congo. So sites like Zambia the women had pretty good idea about the symptoms. DRC, they had no concept of what they were. And you can see that we asked about high-risk groups. We asked about preventative practices. We asked tons of stuff. And this is just to show you that we have this kind of data. We asked about the practices. So did you plan to avoid healthcare due to COVID? And so many of the sites, women were avoiding prenatal care, and especially in Guatemala on the far right, they weren't going to the hospital. Every country was different, and they had a different set of issues. So the summary of this, on Alan's suggestion, I took out about half the slides from this, but I think you got the idea that women in our sites had variable knowledge related to COVID. About 30% of the women avoided or reduced prenatal care visits. Something like 10% planned to avoid hospital delivery because of their fear of COVID. About a quarter of the women, I can show you that number, were afraid of getting COVID from their provider. And although variable along the sites, many women planned to stay at home and wear masks. So there was some evidence that the women were trying to protect themselves, but it was highly variable across the sites. We looked, and this is brand new data, on vaccinations. And so in DRC, Zambia, Kenya, Bangladesh, and Pakistan, none of the women essentially had been vaccinated. And in only 2 of the sites, which are Guatemala and India, were there between 15 and 20% of the women that were vaccinated. So there's a huge reservoir of pregnant women out there just ready to get COVID. We asked about their beliefs about vaccine effectiveness, and just look at the overall column with a couple of things marked in red. 28% of the women thought that the vaccines were very effective, and another 20% thought they were somewhat effective. So there's not a lot of belief in effectiveness of the vaccines. And the big numbers down on the bottom where it says do not know, many of the sites, Bangladesh, DRC, most of the women had no information about COVID. We asked about knowledge of safety for pregnant women, and only 22% thought that it was safe for women to get pregnant, for example. On the other hand, about half the women said, well, if it was available to us, we would probably get it. So there was this sort of discrepancy. We asked among the 35% of the women that said they would never get vaccinated, why? And so they're not sure of safety, not sure of effectiveness, fear of side effects, lack of trust. But most of the women were really afraid of the vaccines, more afraid of the vaccines than the disease itself. So just a sort of summary, very large variation in COVID knowledge, attitude, and practice. And I won't take the time to go through it, but there's so much variation among the women in the sites that what should be clear is among pregnant women in the global network sites that a major educational effort would be needed among the women to achieve high rates of COVID-19 vaccination. And then maybe the final group of slides deals with this COVID-19 antibody study. And so at delivery for the last 9 months or so, or a year, we've been collecting samples as much as we can on the women at the time of delivery. And so this slide shows that at some point in time, we had 15,000 of those samples. And so we've looked at it in this particular slide over time. And what you can see virtually in every site over time, the percent of pregnant women has been going up, with the percent of pregnant women that with antibody positivity has been going up, as you'd expect as the pandemic rolled out. But we've tried to also understand what impact does this have. And so this is still new data and we're still trying to understand it. But we looked among women who had a live birth on the far left, miscarriage, stillbirth, preterm birth, and low birth weight. And the rate of positivity in all of those groups was the same. We think the same. I've got to play with this a little bit more. But it doesn't look like if the women are antibody positive, that they have a very large increase, or maybe any increase at all, in the major outcomes that we look at. And so we've been arguing back and forth with one of the journals about the discrepancy between some of the studies which show if you have, if you're infected, you know, the mother's likely to die, the baby's likely to die, there's going to be all sorts of awfulness. And among the population-based studies, we're not seeing much of anything. And that's another whole topic, but I think we finally convinced the journal that what we did was legitimate. We'll see. I'll let you know in a day or two. But anyway, so that's one of the things that we've been interested in, trying to understand the relationship of mothers that have evidence of infection, but that they mostly don't have bad outcomes. And so again, we're trying to deal with that. Another area that we've worked on, which I didn't really understand well, but the impact of the effects of medical utilization or medical care utilization on the impact of the epidemic. Because clearly there have been lockdowns, people haven't been able to get into clinics. And so we tried to understand if some of the outcomes that we saw were due not to the virus itself, but due to the differences in medical care. And again, that paper may be published soon. But basically, this slide just summarizes that, and then I'll just go on to one other thing and stop. Overall, there was a small but statistically significant increase in home births during the pandemic. So there was a small number of women that didn't use hospitals or didn't use clinics. There was a decrease, small, in percent of physician-attended deliveries, which is also what you'd sort of expect. Depending on the measure evaluated, there was no change or a very small decrease on the receipt of antenatal care during the COVID period. But of the various outcomes evaluated, there was only a small but significant decrease in low birth weight, and there was none of the sites had a significant increase in any adverse outcome during the pandemic. So that's a conundrum. I think we understand it has to do with receipt of care, and the studies where they show that COVID is bad are studies where they find women that are sick, they do an antibody test, and then they compare it to a group of women that aren't sick, and those women clearly do worse. But when you look at just whoever has antibodies that are positive, there's probably no difference. So I can go through the summary, but I think you get the idea of the kind of work that we are doing related to COVID-19. And then finally, I think this is the last slide. I just wanted to give a sense of how we work with the Gates Foundation. So the global network, did that study that I showed you on aspirin. They did a number of studies on micronutrients, on multiple micronutrients, and we didn't do that study, but there are a number of studies that calcium seems to have some benefit on pregnancy outcome. So a researcher from Johns Hopkins had gone to the Bill and Melinda Gates Foundation and said, what we need to do is a study where all of those interventions are done at the same time. And we didn't know anything about it. And so they go to the Gates Foundation. The Gates Foundation sort of approved that study. And then it turned out that in Bangladesh, which was one of the 3 sites for the study, it's required by the government to give calcium. So they couldn't randomize pregnant women to calcium or no calcium. So that was 2 weeks ago. And so with some panic, the Gates people and the researcher at Johns Hopkins scouted around, and they found that, well, Pakistan's a possible site for this. So they checked with the Gates Foundation. The Gates Foundation said, yeah, Pakistan could be done. And so almost certainly we are now obligated to recruit 6,000 pregnant women into this randomized trial for a lot of money that will run over the next 4 years or so. And so when I go back Monday, we'll get the final word, but we think that the group in Pakistan, just because of the excellent work they've done over the years in participating in various studies, being able to recruit, I think it's going to work. So Pakistan, for many reasons, is a great place to do research. The hospital right close to Aga Khan University, which is a county hospital, delivers 20,000 babies a year. The outcomes at that hospital are terrible. So there's lots of bad outcomes. Sample size is no problem. And Pakistan's got a population of 250 million people, more or less, in an area about the size of New York State or something like that. So it's geographically, if you stay out of the Taliban controlled areas, it's a pretty good place to work. But it's a combination of wonderful people, incredibly strong research background in an area where there are a lot of bad outcomes. Which brings me back to the reason I came to UAB, which was a very strong institution in an area 30 years ago that was having very bad pregnancy outcomes. And for me, that sort of parallel continues to drive me. So I'll stop there. I probably ran over my time, but thanks very much. It's really a huge pleasure to be back. And like I said, Warner or Alan, I'd welcome another opportunity to come back and spend a little more time. So thank you.
Maybe there are a few questions we can take from those. Are there any questions?
There shouldn't be, because I covered everything just perfectly. So.
Right, and for those online, please feel free to also ask questions or drop those questions in the chat box. So a Guatemalan note the impact on hospital deliveries was especially marked in indigenous groups. Vaccination is now at about 50% nationwide, but with lower coverage in indigenous groups. So somebody from who knows?
I think that's probably Wally, but
okay.
But that's sort of. But there's huge variations not only among countries, but in sites. In the research site in Pakistan, in Guatemala, is an indigenous area of the country, and the services there are poorer, and the women use medical care far less.
Questions? All right, very clear. We'll go ahead and bring Dr. Andrews up.
Okay.
Dr. Goldenberg, I have a question for how does a trainee or junior faculty member from the U.S. get more engaged in?
Yeah, so we talked about that with some of the residents and fellows earlier, but I think the first thing they need is a track record. And there are, what I've always done is use the data sets that we had, like the registry, but over the years, any data set to give people that are just starting out some opportunity to write a paper related to an outcome in a foreign country, low-income country, and so they at least have some credibility to start. And then by participating, like the people at Columbia, a number of them come to the global network meetings, some of the residents, some of the more junior people. And, we've had, I think I said, one of our junior people built a huge relationship on fistulas with somebody in Kenya. Others have gone to Pakistan and started, and the people certainly in Pakistan, and I know the people in India have been very, very willing to take trainees, show them around, get them involved in the research. And some of those relationships are still ongoing, even though I'm no longer in that relationship. But those kinds of relationships are really important. But I think I've suggested to Alan and to other, to some of the residents and fellows, find Alan, find Wally Carlo, and figure out what's something they can do with the resources they have. And the other point I just made is that it's very hard for somebody that's really junior to get money to do a study of their own. And that's often just doesn't work. But if they can attach themselves to an ongoing study with good people, that will often work. And that's the only way I know to really get a career started.
Thank you.
I have a quick question, actually.
Sure.
Is there anything that you've seen through like Pakistani health system that has worked amazingly well, or something that they've been doing really well that we don't do here that we started to implement or people to do here?
The very quick live answer is no.
No.
I wish it were better, but I mean, there's some very good doctors in Pakistan. Aga Khan University, if you go to their hospital, it's like UAB or Columbia or better than most. But in fact, mostly the places are not like that. And there's so many good people, and the outcomes again are so bad that it's hard to say that anything is really done well. I mean, stories. The NICU at one of the community hospitals that would work, only had electricity less than half the time. So ventilators only worked half the time, and all of that sort of stuff. So Sarah and her group worked really hard to try to get solar power and to get so that at least the generators can work routinely. So that sort of can do stuff is really impressive when you see it, but it's not done in any way countrywide.
Can you give me a minute, Rob?
I will give you all the time you want.
I don't have all the time I want. I used to be able to take all the time I want, but I can't do that anymore because Warner's the head of the show. First of all, I want to thank Robert for coming down here on behalf of all of us and taking the time to spend with us. And I just want to say a couple of things that I want the people who don't know Robert, who are younger in the department, to understand. And I could go on forever, but I won't. Dr. Hub mentioned when he introduced Dr. Goldenberg a comment that Robert, or a quote from Robert in the recent article honoring him in the American Journal of OBGYN about Charles Flowers and how Dr. Flowers impressed Robert. And the work that Dr. Flowers brought to Alabama and came here and identified what really wasn't a department, it was a group. It didn't have a permanent faculty. It had a part-time chair. It had dismal facilities. And Dr. Flowers changed all that. And he did it with an effort to improve the care for the women of Alabama, and he accomplished that goal. And he created the genesis of what is the department that you're a part of now, that we're all a part of. So how did he do that? Well, there are a lot of ways he did it. One of them is that he demanded excellence from himself, and he demanded excellence from everyone around him. And that was a palpable feeling that I could feel as a medical student when I first was introduced to this department. And it's one of the reasons that I wanted to be here. Another important way that he did that is he surrounded himself with a team of people, faculty, and ultimately trainees who helped him accomplish that goal. And he brought in people who are capable of seeing that vision and expanding that vision. And he brought in people like Robert Goldenberg. Dr. Goldenberg came here thinking he was going to be a reproductive endocrinology person, and he discovered the plight of women in Alabama and the preterm birth and stillbirth rates and adverse maternal outcome rates and maternal deaths. And he decided he wanted to do something about it. And he was supported by Dr. Flowers in doing that. And just a couple of examples of the things that Robert has left as a legacy to this department that we all enjoy. People don't know this, but not long after he got here, he spent 5 years, I think, Robert, as the state perinatal health director. Spent much of his time in Montgomery trying to improve the healthcare provision to patients around the state of Alabama, women around the state of Alabama. He was instrumental in helping develop what might be the first electronic medical record in the United States. It was the old OBAR system. OBAR stands for Obstetrical Automated Record. In those days, things were not that dissimilar to today, in that we had 2 L&D units that we covered, one here and one down the street at Cooper Green, the county hospital. We had multiple outlying clinics, and we needed a way to get access to patient records at night and on weekends. And there were no desktop computers then, only mainframes, and programming was still somewhat in its infancy. Now, Robert wasn't the programmer, but he helped develop this system that allowed us to print out, the simple act of printing out a medical record at 2 o'clock in the morning so that we would have it. He also understood when he did that, that these data would be extremely valuable for research purposes, because in addition to enhancing the care that people receive, there are many unanswered questions that need to be answered, and he's still doing that, as exemplified by the incredible talk that he's given today. He developed what was then known as the Perinatal Epidemiology Unit. He had people like Sue Cliver and Mary Dubard and others who developed the origins of this infrastructure to do clinical research at UAB, which you now know as the Center for Women's Reproductive Health. That has been built upon through the years. It has been expanded through the years. It's now directed by Dr. Tita, who's the second most heavily funded OBGYN researcher in the United States and was the most heavily funded until, I guess, last year. A lot of us have benefited from that. All of us, in a way, have benefited from that. That's vision, and that's the legacy that Robert has left. He has helped create this infrastructure of excellence, both clinically and in research, at this institution and in this department. And it has made the place a better place for all of us. And we've enjoyed that legacy, and we continue to do so, and we will continue to do so. He's pushed people. He pushed me. He was a mentor to me. Robert once taught me that, Bill, first thing you have to do is get the money, and then after you get the money, you can figure out what you can actually do. But you can't do anything until you get the money. He taught me that and a lot of other things. He also told me one time I needed to sacrifice a little quality for a little more quantity. But anyway, I sort of got a reputation by the end of the 90s and the early 2000s for accomplishing and publishing studies that nobody thought could be done. I didn't think that could be done either. The reason that happened is because I would say, and many others would say, well, we can't do that. And Robert would say, well, why can't we do that? And so we did it. But we did it based on an infrastructure that Robert developed. It started in the early 80s. I think the first big grant was the Creasy March of Dimes Preterm Birth Prevention Grant. It got built upon from that point that led to literally hundreds of publications and millions of dollars of grant funding that have come through this institution and have gone to other institutions across the country and now across the world. So this is Robert Goldenberg. So we just want to thank Robert for coming down here. We have a small token of that we want to give him. It's not much. It's just a little plexiglass plaque that thanks him. It's a small little token. But what I want Robert to understand that the respect and the admiration and the love that's behind it is not a small thing. And we appreciate everything you've done for us. And we want you to put this in a place that you see it frequently. And I want you to think about us when you do that, because we're thinking about you. Thanks, Robert.
So let me just say, I have another plaque that I keep on my wall, and I don't remember the exact words, but it says why UAB is so special. And it's special because it cares for the people, the women of Alabama. And at least when I came here, I had some questions about whether they were doing that all the time, but I'm hearing that it's getting different and better. But that was what I thought was so really special. And I met a couple of the prior residents just as I've been wandering around. A guy named Herb Cannon, who was the chief resident here when I came. The one thing that Charlie Flowers did was populate the state with great obstetricians that he trained and that continue to get trained. And that a lot of the improvements that we see in all kinds of stuff in Alabama has to do with the training of really good residents year after year after year. And again, it's been a while since I've been back, but I know if you go to Dothan or Mobile, Huntsville, there are well-trained docs there who set the standard for care for women. And if there's a legacy of Charlie Flowers, I think that's it. And my most proud award was being named the Charles Flowers Professor, which I just loved. And so I hope you guys invite me back. Would love to come back. And I'm just thrilled with sort of everything that's happened. So thank you again.
Well, thank you all. Thank you everyone for coming, and we're going to keep the chat box open, and if you want to drop a message for Dr. Goldenberg, we'll collect them and get them to him. So thanks everyone.
Bill, thank you.
That was great. It was awesome.
Thank you.
Robert. You always have an excuse to come back. We
I'm
may need
open.
your